for the January session, engaging people with substance use and substance use disorders. I have a few administrative announcements before we get started. First, I want to discuss the three different sectors that we are engaged with. Civil society, we have some upcoming events. On the 1st of February, the Vienna NGO Committee will host a Global Coalition Civil Society Forum in collaboration with the New York NGO Committee. We will have two sessions, one from 9 to 11, the other from 4 p.m. to 6 p.m. Central European Time. And all of you, coalition governments, are encouraged to attend and to hear from civil society organizations. Then we will also have Global Coalition national dialogues between governments and civil society organizations. The United States will host its national dialogue on January 24th, hosted by the White House Office of National Drug Control Policy, and this is open to U.S. civil society organizations. We have already shared background with them on the coalition, and we are inviting them to deliver statements at that meeting. We will be recording the event, and we will be posting it on our website. Likewise, we invite all of you colleagues to also host your own meetings with your own national civil society organizations to discuss the Global Coalition and synthetic drug threats. And when you do host the meetings, please send us either a video or some type of written summary that we can post on our website as well to share the good work that you've done. Now, I also want to share that the Vienna NGO Committee has committed to collect additional feedback and recommendations from civil society organizations. And again, we will be posting this on the website to make it available to all of you. The next sector is the university sector. I would like to introduce ICU-DDR, which is the International Consortium of Universities for Drug Demand Reduction. It's an NGO that was established in 2016 with funding from my agency, INL, and it currently has 422 university members from around the world. ICU-DDR will convene universities to reflect on the challenges of synthetic drugs and to provide us with research, policy ideas, and programming recommendations. The discussions will focus on all three working group themes. So even though it's a demand reduction-based organization, it will also be discussing supply reduction as well. There are three activities that will be undertaken. First, regional focus group virtual meetings in 6 regions of the world: Africa, Asia and the Pacific, Europe, Latin America and the Caribbean, the Middle East, the US and Canada. And the goal will be to develop recommendations and to prepare a report for all of us, government representatives. This will take place between February and March. Then between April and June, 6 regional virtual meetings with universities and governments will take place to discuss recommendations and incorporate views from government representatives. So we invite all of you to join those meetings. Again, a report will be developed for the coalition. And finally, in June, ICU-DDR will conduct an inventory of university initiatives that can support the Global Coalition's work and document those on the website. The third sector is the private sector, and we will share with you next month an engagement plan on how to collaborate with the private sector. Next, I want to share with you that on the coalition website, we will have a new feature this coming month that will be very similar to LinkedIn, Facebook, and YouTube. It will be a feature of posting and commenting on those posts. The feature will go live in February, but it will require you to activate an account. So as coalition participants, you will receive an email that will invite you to create an account and to post content on the website. We welcome you on our coalition website in this new feature to post news, experiences, but most importantly, recommendations for the coalition. Here is a sample view of what this forum will look like. And you could see there that you have kind of a block where you will be able to post, add images, and sort of share with different communities. And it will be a wall, like I mentioned, like other social media accounts, where we will be able to share and read each other's comments. Now I want to share with you and end with a forward look at the initiatives that we are building and the pledges and this process. We are building what we are calling an initiatives menu that will have either programs, actions, or policies documented. Between the months of January and December, we asked our 11 international organization partners to develop a menu or a series of initiatives and send them to us. To date, we have received 118 initiatives from international organizations, which we are reviewing. During the months of January and February, we will be posting these initiatives on the coalition website in a new section that we will call Global Initiatives. And this is what they look like. We have the title of the initiative or the project, a brief description, background documentation or videos, accomplishments to date if they are existing initiatives, program activities detailing the different steps in undertaking the program. We have outcomes at the global and national level, the names of any countries that are participating currently in the project, and a point of contact in case there is interest on your side from you to participate in these activities. So throughout the months of February, we will continue posting these initiatives on the website. Then between February to March, we are going to invite all of you to provide pledges on these initiatives to say our country would like to participate in this activity or that activity. So we'll be looking for you to express interest. And we will have another opportunity to further discuss these initiatives at the Commission on Narcotic Drugs, the CND in Vienna, for those that will be attending. And then between April and July, we will begin implementation of these initiatives. So I want to conclude by saying that in addition to the initiatives, we are also going to have some high-level recommendations in terms of actions that we will be taking. We have been reviewing the topics from these meetings from December to February and creating a draft list of recommendations. Those recommendations will be shared with co-chairs and posted on the website. And then on the 6th and 7th of March, we will have our working group meetings where sub-working group co-chairs will present to working group co-chairs the list of recommendations and the progress that has been made to date. Those recommendations will be posted on the website, and we will again invite you all to provide further input through this posting mechanism, which I just shared in the previous slide. So that was a lot of information. We will post the recording online if you missed it. And I would like to now turn it over to our co-chairs for tonight's session. And thank you very much for attending.
Thank you, Brian. Thank you so much. Thank you for sharing the progress that we have made and telling us the roadmap. It's really exciting to know that we have a lot of activities lined up for us in the future. In today's session, I welcome you once again. Thank you for being here with us. Today, we are going to have 3 presentations, and we'll be focusing on populations with specific needs as well as families and how they play a critical role when it comes to substance use disorders in general and synthetics in particular. We look forward to your questions and comments on these presentations. So if you prefer to type, please use the chat box whenever you have a comment to make or a question to ask. We will take up your questions and comments after all the 3 presentations are over. In case you prefer to speak, please wait till the end of the presentations. There'll be an opportunity to have an open forum and discussion at that time. So let's begin with the first presentation. The first presentation is about child interventions for living drug-free. In fact, we have 2 speakers for this presentation, Dr. Hendree Jones from University of North Carolina and Dr. Rajesh Kumar from SPYM India. So they both will be speaking on the initiatives, the novel interventions that have been created for children who have substance use disorders. So I invite both Dr. Jones and Dr. Kumar for their presentation.
Thank you so much, and good morning, good afternoon, good evening to all of the many participants. It is an honor and a privilege to be with you all today. And hopefully you can now see my slides. So here we go. Whoops, I apologize. There we go. All right. So yes, I just for more complete context, I am a psychologist by training, and as well as an administrator and also a clinician. And so what I'm going to be sharing with you today is I packed full a lot of information on my slides in hopes that you would be interested to go back and review them. But I invite you to listen to the story that I am going to share and that Dr. Kumar from SPYM is also going to share with you. And truly, this project, this child project, was an act of Congress. Literally, the United States Congress, thanks to the INL leadership, became aware of children who had been exposed to high levels of substances and adulterants, particularly opioids, in Afghanistan. And they wanted to find out more about this and what could be done to help the children who have been exposed to opiates and toxic adulterants, as well as the women and families. And so from that, the Women and Children's Centers that INL set up in Afghanistan asked for some support to help improve their human resource infrastructure, how to treat children that truly had a substance use disorder. So we created and implemented psychosocial protocols for the children. We started with education because that is something that no one can take away from a child or a person. We then layered on different types of life skills, and I'll tell you a little bit more about that. We had a beautiful pre and post evaluation of over 700 children that has been published. And from that, we then began to expand to look at other places in the world where children that have substance use disorders might be identified and then helped. We found them in Brazil. That led to a training in 2013 for people from Chile, from Paraguay, from Brazil, as you can see here. And then with more Colombo Plan support, it was expanded. This training was expanded for people in Bangladesh, in India, and Pakistan. We have a whole cadre of master trainers now. We then moved to South America in 2018, where we have trained individuals in Argentina, in Chile, Paraguay, and Peru. And thanks to Dr. Kumar and SPYM and the National Institute on Drug Abuse and INL funding through Colombo Plan, we have a randomized clinical trial that was started in 2018 and completed the very end of 2023. So you might ask, what is in this child protocol? So we have a total of 6 courses. They are very hands-on, they are practical, they are interactive. We were challenged to come up with courses that would truly help practitioners understand what children were thinking and feeling, how to communicate with children, how to understand the trauma and adverse childhood experiences that they might be facing in their life growing up in drug-using circumstances. We also had pharmacological treatments because we know that children have tolerance. They also have withdrawal that deserve to be treated in a humane fashion. The most beautiful part of our child work is what we call a suitcase for life, which are highly interactive modules for children that teach them a whole variety of different types of skills, everything from art therapy techniques that are used to more sophisticated dialectical behavioral therapy interventions. We also, through this work, developed the world's first comprehensive assessment so that we can understand how drug use has affected the child in their many life domains. And most recently, we have developed a parenting course that is now in the piloting phase, because we certainly understand that children cannot be treated in isolation. While many of them might be in street circumstances, we also know that they still have families or caregivers. And if we can empower those caregivers and families to better support and nurture the child with healthy attachment, the opportunity for long-term recovery becomes much greater. Finally, I should mention that we also have a training of trainers. This is just a few examples and pictures. All of the modules and courses have been translated into Spanish. So we use motivational interviewing techniques, mindfulness techniques. We have toys, as you can see there, that we use because we're working with children between the ages of 4 to 12. This is, in super brief, our randomized clinical trial overview that we completed with the help and support of SPYM, which you'll hear about in just a moment. We had 344 children that signed consent and were eligible for the study. We randomized them. You can see here, that means that they, by chance, were either randomized to child plus usual care or usual care, which is a very rich array of residential treatment that Dr. Kumar will share with you. You can see that among the children, 53% were using solvents, 36% had a primary cannabis use disorder, and 11% had an opioid use disorder. We had a very high rate of completion at 12 months, as you can see there. And these are just a few, one little small snapshot of our outcomes. As you can see in the far left-hand side, we had a very high rate of completion of residential stay. There was not statistical significant difference in residential stay between the groups. The treatment intake, every child, of course, had to have a substance use disorder. So you see 100% had either reported as substance use by self-report or urine drug testing. And at 12 months, what we see is that while both groups did well and showed sustained reduction of drug use measured by self-reported drug testing, it was child plus the usual care that seemed to have the least positive rates of substances at 12 months. So I want to thank the INL and Colombo Plan and UNODC and the many governments, and most importantly, or equally importantly, the children and the staff and the families that have shared so much of their wisdom and their time with us to help bring you what we shared today. And these are some of the publications that we have that I suggest that if you're interested in, please take a look. And I'd like to turn it over to Dr. Kumar. The floor is yours.
Thank you. Good evening, good morning, good afternoon. And thank you, Dr. Jones, for all the effort you have put to develop this model. And thanks to co-chair Dr. Yatanpal. And special thanks to Brian. Without his intervention, his support, we could not have carried out this. Thank you very much for this. Since I have just 2 minutes, so what I'll do, I'll just introduce SPYM for the larger audience. This is around 40 years old organization, and we have been working since 1984-85 in the area of substance use prevention, treatment, rehabilitation. In 2010, we realized that a lot of kids are in trouble and they needed some support. And Honorable High Court of India, High Court of Delhi and Supreme Court of India, they invited us to start treatment, and we had no clue what to do. So we learned over a period of time, and we run 3 treatment centers in the country. One is for the children, those who are in conflict with law. And in fact, that was one of the first centers in India where drug use was decriminalized. It was not so easy, but thanks to the High Court's intervention, we started this project. And this project has been treated more than 4,000. There's a part of the slide, just 1 second. Yeah, around 4,000 plus kids. And all these children are referred to us from the court, Children's Court. We call it in India Juvenile Justice Board. And we have been running another 2 centers, one for the children, those who are not in conflict with law at the moment, but they have been using drug, and where the study of Dr. Jones has been carried out. And where also we have treated around 3,000, between 3,000 to 4,000 kids. And third center we have started, and that's the only center in India for girls, where the girls, those who are substance users, they come to us and we treat them. Treating is only one aspect of the whole program, bringing them to the treatment program, treatment, reintegration back in the society or in a school. And a lot of our efforts go with the families, because the families, usually they are, initially they are in denial. Then the reintegration becomes, especially for the girls, reintegration back in the family is very challenging. And this is just tip of the iceberg. The problem, the last study of Government of India, which says that around 4 million kids in India, they need treatment today. And it's a very big number. Still, in India, we have not recognized that the kids are in trouble and they need special support. So what SPYM has been doing for last almost 30-40 years, we have been engaging with the government, and that is that's our strength. We develop models, we take back to the government, we say that, okay, this is working, is it possible for you to try? So recently we have developed at the request of Government of India a module called Navchetna, and that's part of that is there in slide. Navchetna, we are training master trainers, 1 million master trainers all over the country, and around 10,000 teachers by till now have been already trained, and they will be further training teachers down the line. And the idea is to reach out at least 50 million kids in next 2 years' time. So this is a very, very big program. And in fact, when the UNODC, the representative came under the leadership of Dr. Rahul Gupta, they all appreciated this module, and they said that we would like to also take this to another 120 countries. Some forum has been developed. So that is one important thing what we have developed, what we could share. For the treatment also, we have developed SOPs. For treatment, we have developed a lot of techniques and therapies which are applicable for the children's recovery. Apart from this, we have developed 2 more interventions. One is called peer-to-peer, and now that intervention has been taken by Government of India for 300 districts in the country, and that is also doing very well. And last is, situation is challenging. We have to work very hard. Unfortunately, the chemical drug is in India now, especially for the middle class and upper middle class young kids. And in last, Dr. Yatanpal can also share the experience, what he has been seeing the kids. Kids between age 14 to 18, and especially we have this vaping, this instrument, which is officially banned in the country, but e-cigarette. And that is being used for methamphetamine or methamphetamine types of substances. We are not aware the magnitude and the extent of the problem, but every day we receive 1 or 2 calls from various the sources. They said, can you help us? We have no clue what to do with them. We have no idea how to address this growing problem. So the chemical drug is huge, and that is percolating down from the upper middle class to middle class. And we hope that it should not percolate down to the poorest of the poor. Then the problem will be huge. And the worst part is the availability of these drugs are very, very easily available in the neighborhood. So I'll stop here, and I hope that at the end, if there are some questions, I will be happy to reply. Thank you.
Thank you, Dr. Rajesh and Dr. Jones, for sharing these excellent initiatives, a comprehensive package, and on top of it, telling us and showing us that it works. It works in one of the most stringent kind of scientific study that one can plan. Of course, it's time to now take it up and scale it up across different settings. Thank you so much. We move on to now the second presenter. Our second presenter for this session is Dr. Wataru Kashino. He is Program Officer, Drug Demand Reduction, UNODC Regional Office for South Asia. He'll be talking about family-based treatment packages. Dr. Wataru, please.
Thank you so much, Professor Yatan, for your kind introduction. Can you hear me well?
Yes, please go ahead.
Yes. Yep. Thank you so much. So good morning, good afternoon, good evening to distinguished representatives and also experts of the member states, and also dear colleagues. My name is Wataru Kashino, Program Officer for Drug Demand Reduction, internal medicine physician and psychiatrist by training, and currently working, joining from Colombo, Sri Lanka, and working under the regional office for South Asia of the UNODC, affiliated with Prevention, Treatment, and Rehabilitation section of the UNODC headquarters, Vienna. It is my great pleasure and honor to be here with you today. And yes, so I'm very pleased to talk about the development of a science-informed, skill-based, scalable drug treatment package for adolescents with drug use disorders and other risky behaviors, including those in contact with the criminal justice system. So why we need to get family involved in the treatment process? As you will be aware of, there are so many reasons because the family can be both protective and risk factors. So these listed are just a part of the reasons. But for example, family dysfunction and the problems can lead to the drug use initiation and continuation of the children and adolescents. And chronic conflict, violence, and physical, emotional abuse, neglect have a huge impact on vulnerable family members, especially children and adolescents. And adolescents and also young adults with multiple adverse childhood experiences, so-called ACEs, as Dr. Jones already briefly mentioned, known to be at a greater risk of substance use, emotional control dysregulation, mental, physical, social health issues, and other risk behaviors, including school dropout, early pregnancy, among others. And furthermore, people with severe mental health disorders, including substance use disorders, often don't come to treatment on their own decisions. So therefore, we need a support from family members or caretakers to bring them to the treatment settings sometimes. And the family member can facilitate treatment initiation and support treatment and recovery process, improve retention of a family member with drug use in treatment settings. But often family members don't know how to deal with the drug use problems of their children. Often they are in desperation. Conversely, dysfunctional communication undermine quickly and easily gains from the treatment and not effective and even harmful in treatment process. So sometimes treatment needed to be provided to the other family members with drug use. So therefore, these complicated and systemic problems rarely can be addressed by individual treatment approaches only. Therefore, it is imperative to complement and introduce the systemic approaches like family-based intervention, family therapy, or family education to increase the possibility of successful treatment and recovery support for adolescents with drug use disorders. This figure is summarizing family problems associated with risky behavior and health issues of adolescents. For example, family history of problem behavior, family management problems, family conflict, favorable parenting attitude and involvement in the problem behaviors associated with substance abuse, delinquency, teen pregnancy, school dropout, violence, and depression, anxiety of children and adolescents. So to address these complex systemic issues, so family therapy is one approach because it is one of evidence-based treatment interventions recommended in the UNODC WHO International Standard for the Treatment of Drug Use Disorders and the WHO MHGAP, Mental Health Gap programs. Because it has a strong evidence for treating adolescent substance use and drug use disorders and other conduct problems, including violence and delinquency. However, there remains substantial barriers to its scale-up in community settings under the public domain. So in this context, UNODC, in collaboration with WHO and leading experts and researchers in family-based intervention field, with the funding support from Japan, developed a science-informed, skill-based and scalable treatment training package with element of family therapy. Supporting adolescents with substance use disorders is very much in line with the international policy framework, including Sustainable Development Goals, Convention on the Rights of the Child, UN Guidelines for the Prevention of Juvenile Delinquency, CND Resolution 58/2, UN General Assembly Special Session on World Drug Problem, UNGAS Outcome Document 2016, and the CND Ministerial Declaration. And this study result from the studies of the MDFT, multidimensional family therapy. But so family therapy in general could work to reduce adolescent substance use compared to the usual treatment, in this case, individual psychotherapy. At the same time, also family therapy approach could reduce the adolescent delinquency, including violence. Some family therapy programs has been developed and applied for the gang-affiliated youth as well. For example, one RCT on FFTG, randomized controlled trial on functional family therapy for gang, demonstrated a reduction in recidivism and substance use for high-risk youth. However, the problem is still these programs require considerable resources, such as well-qualified, trained experts in intensive, well-structured, repeated sessions, and well-organized, arranged treatment settings, etc., etc. So to address this issue, UNODC has been developing a series of family-based prevention, treatment, and care programs with families and caretakers, from health promotion and primary, secondary, tertiary prevention, early intervention, treatment and care, and recovery management, and social reintegration support, and relapse prevention. In support of the member states in their effort scaling up evidence-based effective drug demand reduction approaches in each country. So including Listen Fast, Family United, Strong Families, guidance document for prevention and treatment for girls and women, and the GLOCK 42 prevention treatment program for children and mothers affected by drug use. TreatNet Family is part of this initiative. And also how we supported the development of guidelines, WHO guidelines for identification and management of substance use in pregnancy, and also UNODC WHO international standards, and the Stop Overdose Safely initiative to promote the community-based overdose prevention. All the programs are open source technical materials. We took, in the development of the TreatNet Family, key element approach, core element approach. We identified the core common factors across the different evidence-based family therapy programs and integrated them in the TreatNet Family training package. And then this TreatNet Family training package include theoretical foundation for assumptions and cultural issues, the treatment phases, interventions, and assessment method, including positive reframing, relational reframing of family relationships, perspective taking over other family members, relational questions, going with resistance to see the positive changes. And also practitioners facilitate problem-solving practice by the family members in coordination, collaboration with adolescents with drug use disorders. So rather than being the knowledge transfer, the training package provides opportunity for practitioners to practice their skills, how to intervene the problematic family relationships and communication to reduce substance use, at the same time prevent the other risky behaviors. The TreatNet Family has been integrated in the UNODC TreatNet training programs as a volume F, which is already available as open source training materials on our website. Just let me introduce some highlights from feasibility studies in Indonesia and also Vietnam. So the TreatNet Family training package well received and by the practitioners in community settings, and also successfully implemented in community settings in Indonesia and Vietnam. And then, so we observed a significant reduction in substance use and substance use related problems, such as fight, argument, money problems, being arrested, and also so involvement with peers with other risky behaviors. And also we identified improvement in mental health problems of youth and also family members. At the same time, we found general family functioning improvement over time after the introducing the TreatNet Family interventions, reported both from adolescents and also family members. And also we had positive responses from adolescents and families participating in the feasibility study in Vietnam. For example, the mom talks nicer and I feel happier, one adolescent shared with us. And while we saw our practitioner, my mom and I talked to each other what we'd never done before. My parents talk more to me. I feel closer to them. Before I entered the treatment center, I was hardly home. Now my dad comes to see me every week. Before, when I was home, I wasn't close to my dad, but now I see that my parents care much about me. So with this TreatNet family intervention, we try to mitigate and improve the problematic relationship, communication in family settings to reduce the substance use disorders and also mitigate substance use disorders and also prevent other risky behaviors, including violence and delinquency. Since 2010, UNODC has been scaling up evidence-based treatment and care approaches over 85 countries, mainly low and middle income countries, including 33 countries where we introduced, piloted, and also implemented the TreatNet family. So the original development of the program supported by Japan, but at the same time, implementation has been supported by the USINL, France, Italy, Sweden, among others. So as a ways forward, we are planning to scale up the program while continuing adaptation and enhancement in context of each country, as well as ensuring do no harm principle with this psychosocial intervention. And also we are exploring opportunities for effectiveness impact studies through the randomized controlled trials, because previously, previous studies done was only with the interventional group. And also we are developing online self-paced courses on TreatNet family, as well as trying to develop remote supervision mechanism and also training package for the supervision, and exploring a linkage with other UNODC mandate areas such as crime and violence prevention, and the prevention of the recruitment to violence extremist groups, etc. So in this regard, we are very much looking forward to further working with you and collaborating with you in our effort to scale up the systemic family-based interventions for treatment and care of the adolescents with substance use disorders and support family members affected by the drug use of loved ones in disparitions. So for more information, so some very short video clip is available through YouTube. So introducing stories of life and hopes, TreatNet family implementation from Indonesia. And last but not least, we are very much grateful for our donors, USINL, and also Japan, Italy, France, Sweden, among others, and also our partners in South Asia, Southeast Asia, and across the globe in support of the people and adolescent families suffering from drug use and drug use disorders. Thank you so much for your kind attention.
Thank you, Dr. Wataru, for sharing this comprehensive package for family-oriented interventions. Of course, family plays a very critical role when it comes to substance use disorders. And you have very well highlighted that they don't only play a role when it comes to treatment only, but they can play a very critical role for promotion as well as prevention when it comes to substance use. Of course, they may need support on their own at times as well. So they have to be used as a very critical component in the recovery process of those who have substance use disorders. Thank you so much. We again go back to Dr. Jones for our final presentation. One of the many hats that she wears is that of a global coordinator for Global Women's Network for providers of substance use disorder treatment and recovery services. And in this presentation, she'll be talking about interventions for women with substance use and substance use disorders. Dr. Jones, please.
Thank you so much. And it is such an honor and a joy again to be able to bring you a different project, yet I would say overlapping and related. And so this is our beautiful new logo. We have not officially launched yet. So all of you are in on our secret surprise for what a global women's network for providers of women's substance use disorder treatment and recovery will look like and will be. Why would we want a specialized network for providers of women's substance use disorder services? I can tell you from everybody that I have talked to around the world, it does not matter what country you come from, I hear the same theme, which is women are scared to go to treatment. They are more scared than men. They find more stigma when they are able to look for treatment or enter treatment. And often when they go to treatment, they are treated like men. And we know from science, from decades of science, that women initiate substance use differently than men. They need different specialized treatment from men, and they need to recover differently from men. And when they're given women-centered services, women do just as well, if not better, than our male counterparts. You can see in this slide that while, for example, let's look at amphetamines, while women make up 45% of the sample of past year drug use of amphetamines, they are only represented by 18% in treatment. And so you can see that across the whole spectrum of this slide, that many fewer women are able to get into treatment. Often there is no treatment for women. And so this network is to give hope, it's to give voice, and it's to give action in tangible, practical ways that anyone who is interested in expanding access to women's treatment, improving the quality of care for women's treatment and improving outcomes could do so. So the Global Women's Network's mission is to create a community where providers feel supported, where they're nurtured, they're empowered, they're given education, tools, and practical knowledge to help increase the workforce, expand it, and strengthen it. So we are creating a whole network to improve treatment services, to make sure that any woman who wants treatment, including those in the criminal justice system, can have access to high quality care and can receive life-changing care. So what does the GWN propose to offer? We've already started with a soft launch. We've been having monthly, what we call digital events. And then one of our participants said, they're not just digital events, they're practical knowledge programs. And so that's what we rebranded. What we're doing, we gather each month, we have anywhere from 50 to 70 providers of women's substance use disorder services, and we give top 5 tips. Just last week, we did a top 5 self-care tips. And people come and they talk and they're engaged and it's lively. And we have over 14 countries that are represented. So that's just one example of what we're doing. We're also going to be launching mentoring meetings, because so often what we hear from providers is that this work is lonely. I feel isolated. I don't know what to do. So creating mentors and mentee relationships can help strengthen the field. Of course, we have a long history of women's treatment. We started with GROW, and then the most new course is WISE, and we have 4 of those courses. And then we're also going to be developing practical resource toolkits for every question, every sort of topic that our providers want. We have the ability to respond with a practical toolkit. For example, trauma. How do we work in mixed gender settings with patients that have been traumatized, that have been sexually assaulted? We have a toolkit that can be created for that. We also will have news you can use, those practical pieces of information that we will be sharing and then collecting from others, collecting the wisdom across the world so that everybody has access to the most practical and best, most helpful resources to improve access to treatment and quality of care and outcomes for women. And then finally, the other thing that the GWN will aims to offer is evidence-based technical assistance, a beautiful package that is tailored for each individual program, community, or even on a countrywide level. And in thinking about how most places approach treatment, there are 3 categories that we often see. We have people that have come to us that have said, I've never treated women. In fact, I've never even thought of them any different from men in treatment. Help me understand what I need to do to create a program from the ground up if I have only men's services. We have skills and tools that will help you do that. The next and probably most common area are programs that are treating women in men's centers. And often what we hear is that there are many male-focused practices. And so if you can feminize those practices, create safe spaces for women, they can really not only be resilient, but they can thrive. And then finally, we have programs that have been treating women in women-only settings. And sometimes they're like, we want to improve our outcomes. So again, we aim to have toolkits that can be able to help support and nurture those programs so that we can improve treatment processes, and outcomes. And so just to end, I wanted to share with you some of the thoughts from the providers of women's treatment that they've shared with us, which is that we feel lonely and isolated in our work. And I can tell you every day, I get at least one email from some provider around the world that says, thank you for those tips. I feel less alone. I feel in community. Our providers have asked to help women access treatment by increasing information and treatment spaces. So helping us understand how people are finding out about treatment, where treatment is, where the gaps are. Providers have said we need training to achieve both gender awareness as well as more cultural awareness among our staff, as well as our patients and our clients. They've asked for help in addressing gender violence and stigma against women, and also to create appropriate spaces for both sexes so that everybody can feel comfortable in treatment, to feel empowered, affirmed, seen, and heard. And finally, I'd like to leave you with some of the quotes that women have told me throughout the years that I've had the honor and privilege of working with women in substance use disorder treatment facilities. And the first is, please don't judge us, because believe you me, there isn't anything that you could say to me that I haven't already said to myself. I have tremendous shame and guilt being a woman who has a substance use disorder. Second, please give us empathy. Please give us practical skills and support so that we can change our lives, so that we can find recovery and live recovery. Third, let us be active partners in treatment. Don't let treatment be something that's done to us. Let us partner and be active participants in that treatment. And finally, help us be the best parents we can be. Don't tell us what to do, but show us how. And that is what the GWN aims to do. And I'd like to acknowledge all of the many important partners: INL for support, Colombo Plan, CCAD, UNODC for serving on our expert advisory committee. You can see all of the other wonderful individuals that we have there. And with that, I will stop. Thank you so much for your time and attention.